Really doesn't own, university owns. Is that right?
That's correct. I don't know about the number, but they own it.
I counted them. And so today he's going to give us an upgrade on this one, UPenn partnership, a model for global health engagement.
Okay, thank you. Well, thank you for the invitation. Okay. Well, I'd like to, I'll fill you in on this program that came out of nowhere, really, for me and for Penn. And I'll explain to you how it happened and where we are today. And I don't mind if there's questions as we go along, but I think there's also going to be time at the end. Whatever. So I wanted to tell you first a little bit about Botswana and how Botswana became a target for, is that on? Push it away. Oh, use it, because can you hear me back at the end? Yeah. All right, you want both. Okay, if it's echoing, let me know. How Botswana became a site that was preferred. So I'll jump ahead a little bit. We got invited to go to Botswana by the Merck Foundation and the Gates Foundation. And they had partnered with the government of Botswana to start an HIV treatment program in Botswana. And they were looking for doctors that could help with the rollout of a national HIV program. So why did Botswana become the favored child for Merck Foundation and Gates Foundation? And some of the reasons are shown on this slide. Botswana was a British protectorate colony until 1966. At that time, the Brits left, and it was shortly after that, in the history books, it's shortly after that. There's stories behind it, which I'll tell you in a second. But a few years later, Botswana discovered that they had ample, plentiful diamonds in their northern regions. And so actually Botswana is the #1 high-quality diamond producer in the world. They make about 35% of the quality diamonds that are sold globally. But they didn't discover diamonds till 1968. The Brits left in 66. But the discovery of diamonds has helped drive their economy. It makes up well over 1/3 of their economy, and they have used this money well to support the development of their society, including medical care. Now, so one of the reasons that Botswana was selected is that it was an English-speaking country. Another reason, it was a democracy. They've had 4 presidents since their inception. They've all been elected presidents, and it's one party that's been in power, but it's always been an open and fair election. They have what's considered to be very low corruption rate, and there's an international ranking of corruption. Botswana on the global percentile is 17th percentile. So where's the U.S.? Well, I'll give you a chance to think for a second, and then I'll answer it. But I'm going to go back to the diamond story. The reason the 1968 was the official announcement by Botswana that they discovered diamonds. I was at a 50-year anniversary of their independence last year in Washington, and the daughter of the Minister of Finance, or the Minister of Mining, was there. And she said her father knew about the diamonds in 1965, 1966, but they didn't want to say anything to the Brits because they were worried they would never leave. And they were right. They were smart. But so it was only officially recognized. So what is the U.S. for corruption? Well, so Botswana 17%, but ranks lowest or best, lowest percentile in Africa. But U.S. is 9th percentile. So we're not bad. Then that was before this administration, so all bets are off. Safe, low corruption, English language, which makes it easy for U.S. people to be there, and a pretty robust economy. They're a middle-income country by World Health Organization standards. Okay. Well, I'll just point out the location. So here's Botswana sitting just above South Africa, and the capital is Gaborone, but Gaborone is how they would pronounce it, sitting in the southern tip here, southeastern tip of the country, very close to South Africa. South Africa is the big giant in the region, the economy of South Africa and so on. Now, Botswana has 2 million people, so a very small population in a mass that's this land mass the size of Texas or France. So it's very rural and spread out. Now, this is a slide I took from the web, and instead of showing the land mass by actual physical size, it shows the territory based on disease prevalence. So the disease we're showing here is HIV, and here's sub-Saharan Africa and HIV. This is North America up here, South America, and you can see the burden. It's to show the burden of disease, the massive burden of disease in that part of the world relative to where we live. Now this shows the physician supply, and here's sub-Saharan Africa, or Africa, and here's the disease burden. Here's the United States for HIV disease burden. This is physician supply in general, disease burden. So you can see the discrepancies that they were facing in that part of the world, and still do. Now, one thing that goes unrecognized is how big Africa is. I've been to Botswana, not that I'm counting, but I've been there 39 times. And each time I fly there, it seems like it's further and further away. But you can fly from the southern tip of Africa for 8 hours and still not be through the continent. You're flying north, and you fly over Senegal, and it's an 8-hour plane ride. So it's huge. Now this shows the United States fitting into Africa, and you can see other countries fitting in here. The 48 contiguous U.S. states is much, much smaller than the continent of Africa. And so it's a huge continent. Botswana, the size of France or Texas, 2 million people. It's a size country that the Gates Foundation and the Merck Foundation felt was a population that if something's going to work for HIV care, this was a good place to test it. It wasn't clear in 2001, when we first got involved in Botswana, that anything we could do in Africa would work. There was a lot of skepticism that the Africans just weren't capable of sticking to drug therapies, following adherence, didn't have the medical supply chain, any of that to make something work. So how did we get involved? Well, in 2001, Botswana had the highest HIV prevalence of any country in the world. 22% of their citizens were infected. In women of childbearing age, it was 38%. And this is a big issue because women pass the virus on during mostly labor and delivery to their infants. About half, a little less than half of those infants, if the mother's infected, they become infected, but not if they're on treatment. But if they're not on treatment, that's the case. The president of the country, Festus Mogai, said, "We are threatened with extinction. People are dying in chillingly high numbers. It's a crisis of the first magnitude. Now, he said this in 2001 to the UN General Assembly. That was a time when Mbeki, who was the president in South Africa, was saying there is no such thing as AIDS. This is all false news reporting in those days, whatever the words were. But there is no such thing as an AIDS epidemic. It's not caused by a virus, and total denial. But the next door neighbor said, if we don't do something, we're going to be extinct as a nation. There were so many funerals in Botswana at that time. The funeral coffin makers could not keep up with the demand. And there was 2 major coffin producers, and they just could not keep up. And there was one of the Botswana colleagues of mine wrote a book about that. Sundays are for funerals. And that was what Botswana was like when we first showed up there. So how did we get invited? So we were invited by the Gates and Merck Foundation that had formed this partnership with the government of Botswana. How did that happen? Well, at that time, I was the chief of infectious disease at Penn. That was a role I played from 1990 to 2012. And at the time of the call, I got the call because the Merck Foundation was looking for doctors to help with the rollout of a national program for HIV care in Botswana. They called me because I was the head of infectious disease, and they knew of us because Merck is, basically our neighbor in Philadelphia, and there were people there that knew our people, knew me, and knew some of our providers in the infectious disease division. So the call wasn't a blind call, but it was unexpected. And I remember when they asked me, do I want to participate, I said, I am interested, but first, really, I'm embarrassed to say this, but where's Botswana? And the reason I said, I know it's sub-Saharan Africa, but if you asked me to put my finger on the map in 2001, I couldn't have done it. Now I've been 39 times. The presidents, they've had 4 presidents, 2 presidents have been my guests here at Penn. One of the presidents has had dinner at my house. I know virtually, everyone at the university that's at the dean level and above. I didn't know a thing about the country in 2001. So what did I do? Well, I said, let's meet, let's talk and find out what we can do. And we called a meeting, and Don Silverberg was there. Yeah, Don, remember, I'm sure you remember being there. Of course. Yeah. So Don was global health for the department for the School of Medicine at the time, and Jim Hoxie, CFAR director. We had about 15 people sitting around a small conference room in the infectious disease division. And the Merck people came and presented their request, and it wasn't clear to us what type of funding, if anything, they were going to offer. And Don was walking in and said, your recollection is there wasn't much money on the table at the time. I don't, yeah.
$50 million worth of product.
Yeah.
No interest in funding physicians.
Yeah, yeah. So negotiating, because what Don said, the deal was going to make the drugs available in country, but how you get the physicians over there, they hadn't gone that far. But so I said, yeah, we went around the table and we tried to decide who had the resources to make a commitment. And because I was head of infectious disease, I was really the one that was in the best position to say something, because even if I wasn't speaking for myself, I was the boss. So you could say, I'll find people that will be willing to go. And I knew we had people in our division that were willing to go. So we were able to negotiate funding for 1 faculty member and 1 fellow for the first year. And since we couldn't just take someone out of their job description and say you're going to Botswana for a year. We send 4 faculty for 3 months each. And the first person I sent was Steve Gluckman, who many of you may know, just a super clinician and loves global health medicine. And then there was others. Rob McGregor, who's well known to this group, was the second one that went. Very experienced HIV provider. Ron Coleman, who's now our CFAR director, was third. And then there was a recent graduate we sent, who was our fourth. But during that year, the ASEF, the Merck Gates Foundation, suggested that I hire someone full-time because this 3-month rotations was difficult. They just get settled in, and the next thing you know, they're gone. So I did that. I hired someone who was a Penn alumni that was working in New York, and he went and spent 2 or 3 years there as our representative. Now, we on day 1, when the first patient was treated with HIV medicines by the, supported by the Gates Foundation, Merck Foundation, Government Botswana, our physicians were on the ground. We weren't the only ones there. Harvard was there for their School of Public Health. They had been in Botswana for probably 5 or 6 years before we got there. And Baylor was there doing pediatric HIV care. And our involvement started in 2001 with this national rollout, but we were the adult infectious disease group that were experiencing HIV care, and so we had a big role to play in how do you actually treat patients. Harvard was very instrumental in how do you set up a public health program for treatment. We were the treatment arm, and Baylor was the treatment arm for pediatrics. And I didn't go over until 2002, and then for the next 14 or 15 years, I spent 3 weeks at a time, 3 times a year. I'd go every 4 months for 3 weeks, approximately, and spend time in country, just making sure the program was moving in the right direction, that we were on target. And I'll tell you what our program is. But we also made sure that we were working collaboratively with Harvard, Public Health, Baylor, Pediatrics, that we weren't bumping into each other, that we would collaborate, not compete. You know, our nature in the U.S. is compete, and in Botswana it was really important that it was seen as a collaboration, working to help build capacity in country. So. So our mission was to share expertise to build capacity, and that really is the underlying mission of our program, helping to build capacity in country. So how do we do that? I'm going to jump to 2017, but I'm going to take a break here to explain a major development. So when we first started, there was no medical school in Botswana. They were thinking of forming a medical school. They didn't have one. We were playing a role teaching medical officers, which are hired people by from the government of Botswana. But these doctors were not citizens of Botswana, and the concern was that you train them and they're gone back to their home country 2 years later. Big turnover. So they needed to form a medical school. The medical school actually started in 2009, and we were there, I was there, we were there, the day of their first class. I remember being at the classroom, their first class. They brought in, I think it was 32 students for their first year of medical school. So that was 2009. So a major mission of ours was to help with medical education. And that is still to this day, I think, probably our most important contribution and probably the most important thing we can do going forward. There's several people, at least one, I see Pierre Rousseau here, who's been there a number of times from pathology, who's played a very important and probably fun role for you in helping to develop medical education in pathology. So medical education became sort of our pet project, key mission, and how do we fund that? So ASEF, Merck Gates Foundation, helped us get started. In 2003, George W. Bush, started PEPFAR, President's Emergency Plan for AIDS Relief. And this was to help HIV care in mostly sub-Saharan Africa. He made money, $15 billion over time, available for HIV care. And because we were in country as of 2001, when the funding opportunities, it was funded through CDC mainly. When it was available, we were very competitive for getting funds, and we've been very successful getting CDC PEPFAR support. It's one of George W. Bush's flagship contributions, I'd say, to healthcare, to what he did as a president. He's very proud of what he did. I'll say, you know, I'm much more democratic person myself. I wasn't a big fan of his, but two things have happened. One, this program is great, and two, Trump. So since Trump came along, I'm a much bigger fan of George Bush. But I mean, you know, I'm sure not everyone feels that way, but that's my view. But you know, he looks really good. But he was really good over this this process too. This was a major accomplishment and really a terrific thing that he did. I'm sure I'm going to show you some pictures in a minute of George Bush, a visit he did to us in Botswana. But I want to just say where we are now. Now, again, I stepped down as director about a year ago. There's a search going on for my replacement. It's still going on. Glenn Galton, who's the director of the Center for Global Health, is the interim director. And there may be some developments that I'm just not aware of in the last little while, but I'm going to tell you most of the things that I know. So mother-to-child transmission, which was 40% of pregnant women would pass the virus on to their child if they're not on treatment. That was a major focus of care, and it's now down to 2% transmission rate, a huge, huge accomplishment. Now, we played a role in that. We weren't alone, but we definitely played a role. Of the citizens that qualify for HIV care, and those criteria change depending on what the WHO is suggesting and what people, you know, we've learned a lot about what's the best time to start HIV care now. And now in this country, as soon as you have a diagnosis, you start care. It wasn't always like that. 90% of citizens who meet criteria for HIV therapy are on therapy. A huge accomplishment. That's better than we have here. The life expectancy has gone up from 39, which was the low point, to now it's in the low 60s. Huge accomplishment. However, I said the new infection rate among young people is down a bit, but not nearly as much as it needs to be. So this whole prevention through education and condom use has not really hit home yet. And the more therapy, as therapy is more and more effective, you know, there's an attitude that, okay, if we get it, we'll have drugs to take, which is very troublesome. But it has been a problem seeing the new infection rate go down. It's gone down a bit, but young people are still getting infected at an alarming rate. So what are we doing there? Now, we basically followed the same format we would if we were here at Penn. We've put our emphasis on clinical care, education, and research. I remember when I first went there, I met with the head of the hospital, and I said, we're going to come and help you with clinical care. And with that, we'll do education. But at some point, because we're a research-intensive institution, we'll be interested in research. And he was fine with that. But not everyone in the country was fine with that. They felt that, you know, there's this concern that if you're doing research, you're just using us to gain for your own career development and so on. And it's been a slow acceptance that research is really a critical part of what we have to do in country. If we don't study what we're doing, it's almost impossible to get the Ministry of Health to change their policies. They want to see evidence to support a policy change. And they've learned, I mean, the country has learned that research is critical to policy development and implementation of new programs. But it was it was not a hard sell, but I made that point. My research is not in HIV, so it wasn't to develop my career. I'm a herpes simplex lab scientist. And this came about for me because of that. I got that call, and it came at a time in my career to take a new initiative on. But it wasn't my science, but it has to be our science. But clinical services was always our #1 priority. We were there to help with an epidemic that was hugely out of control. Hugely. I remember when I first showed up on the wards at the main public hospital called the Princess Marina Hospital. The medical ward holds about 150 beds. The whole hospital is about 750. Medical ward was 150, and it was divided into two, like we used to have here years ago at the Philadelphia General Hospital, these big open wards, and there were a male ward and a female ward, open wards. And each open ward had about 8 beds, and there was multiple open wards. And in a ward that should have had 8 people, there was probably 15 or 20. And it wasn't 2 in a bed, but 1 in a bed, 2 on the floor. And for every patient on a bed, there was at least 1 or 2 patients on the floor. You would show up at the HIV clinic, and the lineup of patients to be seen by the very limited number of doctors would go out the door, around the corner, halfway around the block. There would be 200 patients waiting to be seen. Fast forward to 2 or 3 years ago, the number of patients waiting to be seen in the outpatient department was no waiting line whatsoever. The number of patients on the floor on beds, virtually 0. And sometimes there were empty beds. Now, HIV is still a big problem because people don't get diagnosed until late. About 70% of the inpatients on the medical ward are HIV infected or in there for HIV or a complication. The big complications are TB and meningitis with fungus, cryptococcal meningitis. TB is really a major, major problem in Botswana. But the HIV care has improved dramatically, and it's the people like here that don't get diagnosed until late in the disease that are coming in with far advanced disease. But so our clinical services, we were very active on the general medical ward. HIV was the most common disease, but we were on a general medical ward. And we started sending our students over. So I should back up and just tell you, when I was asked by the Merck Foundation, am I interested? I was interested for 2 reasons. One is the politically correct reason is that HIV care, HIV epidemic was rampant in sub-Saharan Africa, and if we were going to make an impact, we had to have a footprint in that epidemic in sub-Saharan Africa. And a lot of my very close colleagues that were involved in HIV care were very interested in seeing if we could develop a footprint somewhere where in a resource-limited setting. And so that was the main reason. But there was an equally important second reason that was my driving factor, is that I was getting asked by students and residents on a weekly basis, can we have a rotation and an experience in a resource-limited setting? We're infectious disease. They looked to us to do that, and we didn't have a place to send them. Dawn had a program through global health, global health in the school, but we didn't have one place that was sort of set up for easy transit for students and to get a global health experience, and that really appealed to me. And we've done that in Botswana. It's now, the go-to place for our students and residents and for experience. This is one of the first students that went. This is probably around 2004. She's examining a patient. She's a 4th-year medical student, and the doctor with her is one of our doctors, but when we round, we're not by ourselves. It's an integrated service, and now it's the UB medical students, the UB residents. They've started residency program in internal medicine. Our doctors, our students, their students, we're working as teams, and it's a very productive environment. So TB is rampant. Now CHOP was very interested in getting involved in Botswana. I mentioned Baylor was there, and so we decided early on that CHOP would still be in the northern part of the country. Baylor was mostly in the southern part. Now at this point it's all integrated. We no longer do that, but initially CHOP was in Francistown, which is a town in the north, trying again to be good neighbors, and also to help the country, because the northern part of the country was getting less attention. And Andrew Steenhoff was one of the physicians that was in our program. Now he's now the Global Health Director of CHOP and is back in Philadelphia. He left Botswana about a year or two ago to run the Global Health Program here at CHOP, but still very active in Botswana. But we had a team of doctors that would be working in the northern part of the country. Now this is one of our programs, was a cervical cancer screening program. Pap smears are used here. They didn't have the pathology in that time to do pap smears. Now it's better. I could ask Peter to comment on that, but it's much better now. But years ago, when we were starting our program, one of our physicians, who's the lead physician in country, Doreen Ramahola Masiri, she started a See and Treat program where you use vinegar to stain the cervix. You can see if there's lesions there, and you make a decision right then and there what to do. Cervical cancer is extremely common in HIV-infected women. It's the #1 cancer in that population, and it's a major killer in Botswana. And they didn't have good screening procedures, so we initiated a program that eventually became a national program for using See and Treat, staining with vinegar, making a decision, using cryosurgery to excise small enough lesions. If they're too big, they have to get sent to a surgeon for more definitive surgery. A very successful program. Now, George W. Bush, his PEPFAR program was funding the See and Treat, and he was very proud of that program. So he came in 2012 to visit our clinic, and here's Laura Bush and George W. and Doreen, and I was there for that visit too, and it was really pleasant. He was very down to earth, asking good questions, and really interested in what was going on, and it was a thrill to meet him in that setting. Now, another thing that we did that was under the supervision of one of our dermatologists here, Carrie Kavarik, was a telemedicine program. So very few doctors, but cell phones were pretty widespread in Botswana. Almost everyone has a cell phone. Not everyone has one with a camera, but now that's much more common. But cell phones were widespread. Cameras were in pretty wide use. And we started a program where you could be at a very rural site, take a picture of a rash, send it to Carrie here, she'd read it and give an opinion. And then we expanded that to be beyond just dermatology, but to involve dental medicine. There was only one dental oral surgeon in the country, so we started with programs taking pictures of oral lesions, sending it to the dental surgeon, and he could say, come to 500 kilometers to Haverone, or you don't need to come, this can be handled locally. And we've done it for other diseases as well, using telemedicine as a way to improve medical care. But dermatology was our lead. Medical education, so on an average year, I would say there's between 100 and 150 PEN people that go to Botswana. Now, who are those people? About 50 of them are trainees, medical students, residents that are going for clinical rotations. About 50 of them are medical or nursing faculty that are doing something there. And maybe 50 is an overestimate, but on an average year, we probably have 100 to 150 people going. And so they may be going for educational purposes or for research purposes. But it's not easy to go over once and think you can make an impact. So it's not that productive. People like Pierre have gone repeatedly, you can make an impact. If you're going once, you're doing, that's what's called medical tourism, where you go and it's more for you than it is for them, because you can't really have an impact when that happens. Here's Wally Miller, who's a radiologist that is here at Penn, Wally Miller Jr., who's been there a number of times helping to this. We sent radiology residents over there, but he went over to help set up the program, and he did some teaching when he was there during his rotation. So clinical care, HIV, TB, cervical cancer, general medicine, were our early focus. I'll show you where we are now in a minute. Education, mainly through the University of Botswana Faculty of Medicine, that we're very involved in education in that regard. But every time we see patients, we have someone with us. So we're always educating our colleagues. The problem is when we leave, it's not that they can replace us. They don't have the funding to say, okay, I just met yesterday with one of our dermatologists that's been there for almost 2 years. You know, she's worried that when she leaves, there'll be a vacuum. Who's going to replace her? And it's a problem. I think we have some solutions, but this is one of the few times we may solve that problem. Most of the time, it's very difficult because the government, despite their middle income status, they do not have money to spare to hire and hire and hire. The number of positions are very limited. So our research program, it's really based on the interests of the individual. We have a number of NIH grants with a focus in Botswana, and those people can come from infectious disease or elsewhere. We send undergraduates to Botswana for summer internships. We've had programs from Wharton in Botswana, School of Arts and Science, School of Design, and nursing has been a key player in Botswana. At this time, we probably have about $7 million in funding annually from Botswana, and there's a lot of publications coming out of our program, a lot. I put here about 30 to 40 papers per year. I've mentioned the global health experience. It's usually the fourth-year students that go. They work on the wards for 7 weeks. We send them to the main public hospital and to a community hospital, just so they get a view of the difference in the chaotic nature of the experience. The community hospital is sane, the public hospital is chaotic, but they love both of them. And it's been a great experience and then Penn residents in many disciplines, not just internal medicine, although internal medicine is the big one, but many disciplines. I know pathology has started sending fellows this year. OB sends fellows. Psychiatry has sent many faculty. We have a very robust psychiatry program. Our psychiatry under Dwight Evans helped develop the psychiatry program at the University of Botswana. We helped recruit the first psychiatrists. We helped them develop that program. So it's not just internal medicine. And what about the reciprocal? It's much more difficult for us to get their people here, and it's partly money. Well, not partly, almost entirely. Well, two things. Money is a big part of it because Penn pays for our people going there. Who pays for their people going here? And Penn is willing to pay for some, but not a huge number. So that's one. So we bring students over. And we generally have been bringing their two best graduating students for a summer elective over here, and we've been doing that for a number of years, and those students do spectacularly well. They're really good. The second problem is that if you're a resident, you can't get licensed to practice here unless you go through that whole system of USLME tests and then get licensed at Penn. So you can come and be an observer, but you can't touch a patient, you can't talk to a patient. But students can do all those things. Students are learners, they're not doctors, so they can touch and examine and so on. So it's much easier for students to come than it is for residents. We brought residents over. Now we've brought one resident here to train in internal medicine, and he's gone back to Botswana, and he's a star in their program. He's an absolute star. He'll probably be the chair of medicine in a short while. And he's now the one that I'm not in discussions, but Glenn Galton is to see if he'll oversee our students when they're there, to transition from one of our people overseeing to one of their people. A nice transition. We have 8 people in country that we consider Penn faculty. Some of them have adjunct appointments, some have clinical appointments, but they're there. Now, 2 of them are from Botswana. One's in internal medicine, one's in OBGYN. 3 are U.S. trained people that are there. Some are in infectious disease, but not entirely. Some are pediatrics. And then there's a number of other countries. And they're doing different things. Some of them are mostly research, some of them more clinical. And if they're clinical, how do we fund them? Mostly through PEPFAR-related programs. We can fund that. You can't bill for services there, so you can't be a clinician there in the public sector and bill. You'd have to be in the private sector, and we haven't wanted to do that. We've stayed in the public sector. We have a lab that we set up in collaboration with the medical school. Why did we do that? Well, they would prefer, Botswana, that samples are studied in country for research rather than be sent back here, and so we set up a lab with them. They didn't have a high quality lab. Now we have a high quality lab that we're doing in collaboration. Radiation oncology has a major presence in Botswana. The former chair of radiation oncology, Steve Hahn, was very interested probably because, well, he's interested in global health, but also his fellows wanted an experience, the residents. So he went over and he's developed a very strong program that Penn has kept going. He left to become chair at MD Anderson, but the radiation oncology is continuing that involvement. So in the final couple of slides, so we've participated in training their first cohort of medical students and residents. We've trained lots of healthcare workers. We've treated lots of patients. We've done well with funding. Our program there right now has probably 100 to 120 employees. Most of them are from Botswana. What are they doing? Some are working on research projects. Some are working under PEPFAR in patient care-related projects, but we have about 120 people working for us. And I mentioned about the Penn faculty. Who's involved now? These are the ones that came to mind. Department of Medicine, Peds, Durham, Family Medicine, Psychiatry, Radiation Oncology, Surgery. Surgery sends generally 1 or 2 residents a year to work in Botswana. OBGYN, pathology. Pathology has really done a lot in the last few years. What's ahead? Well, HIV, TB are going to be around for a long time. Cancer is getting more and more attention in Botswana as the HIV epidemic has come under control. So I think there's going to be many opportunities in cancer. Cardiovascular disease, diabetes, and mental health are all areas I think we could have a major impact. And our research and clinical care and education should be done in collaboration with the School of Medicine. Now, the School of Medicine is a new school, and it's not been easy working with them. They're basically in total chaos most of the it's you don't realize how privileged we are here to have what we have until you're not here. And you see how hard it is to move something forward. So Larry and Ralph, we thank you for keeping us organized and an incredibly tight-run ship here. But it's a very different operation in Botswana. So nothing is easy. I think I have one more slide. What did we learn? Well, I've been there many times, and one of the key reasons to go is to build trust. Because if you show up over and over again, they start thinking you're serious about what you're doing. And building trust is really important. You can't do it without showing up. Capacity building is difficult. Healthcare workers are in short supply. There are few available to receive the treating. We want to treat someone, but they see a doctor show up. They say, oh, good, there's 40 patients waiting. You do 20, we do 20. We would rather do 40 with them and teach. They would rather do 20 and 20, and it's always a constant battle. They can't afford our replacements. You can't make a decision without getting all the stakeholders. And I mentioned I went to the superintendent of the hospital when I first showed up, and he said, great. And I thought, I'm done. Well, it's like if you went to Larry or Ralph here, you talk to them, and they say, it's a good idea. You'd say, okay, good, I'm in. Well, it turns out that he was not high enough on the totem pole. And it wasn't the Ministry of Health that had said, good, we want you. And it wasn't until 5 years later that I started getting feedback, yeah, we're still annoyed at you for not coming to us, for telling us what you were going to do. You went to so-and-so, but you didn't come to us. So getting the stakeholders to buy in is really important. And you have to be patient. Changes come really slowly. So final thoughts. This is a great program. It's been my pleasure to be involved with this program. Penn has a small footprint globally. I'll say it again. Penn has a small footprint globally. We have a big footprint in Botswana. Beyond Botswana, we have a small footprint. Why is that? We don't have a school of public health. That was a decision made a long time ago. Without that, it's hard to have a big footprint. We don't have a department of global health. If you're not going to have a school, have a department. We don't have that. I think that's a big problem. We have a Center for Global Health, which is new, and that's a step in the right direction. But centers don't hire people. It's departments that hire people at Penn. I mentioned we have 8 people working in Botswana. Who's their boss? What's their security? Who's hiring them? What's the money behind it? These are very major issues that they feel, you think people feel here insecure as faculty, multiply it by 10. And that's what people feel like there. They want an experience in global health. I had money to hire them. I was a division chief. I could hire them through that mechanism. Now, for the last 4 years of this program, I wasn't a division chief. How do you hire people? Who's paying for it? What's the commitment from the school? Big problem. So Penn has a small footprint. It's a big program. We have lots of areas to consider for further development, I think. I'm going to stop. All right. Thank you. So I'll be happy to take questions.
I remember talking with Rob McGregor a number of years ago, who said that autopsies were not culturally accepted by the population there, and he was interested, was there such a thing as a needle biopsy?
Yeah.
And what, if anything, is going on in terms of studying what happens to, well, why people die?
Well, you're right. And I would say that's a very good example. If you want to do something, you have to do it yourself. So Rob wanted to see this happen, but he wasn't in a position to spend 6 months or a year in Botswana to get it started. So it's something that would be a huge advance over where they are now. There's not a culture of autopsies in Botswana. It doesn't mean they never do them. And maybe, Pierre, you can comment. I don't know how often they're done.
So they do them infrequently. I would say probably they do maybe a couple of months. However, they have begun to do fine needle clinics for neck lesions and for breast cancer lesions, there are fine needle aspiration clinics that pathologists participate in that happen at least several times a week, as far as I know. So I mean, they will not go into deep cavities, but the superficial cavities, the pathologists will do needle aspiration.
Yeah. Yeah, what Rob was McGregor was interested in is if someone dies, put a needle in the lung and see if it's TB or something else, that type of thing. And I don't think that has been done.
I was there in May of 2017 neuropathology one day. I said, let's go and I'll show you how to do the brain cutting. And that day there were 2 autopsies. We did the brain cutting out there. So there is a certain amount. I mean, I was not there for long. I will go back and see if we can organize. They have a precise day for autopsy. I understood. The autopsy will be done on Thursday, so not every day. But that day, probably I was lucky. There were 2.
See, now they have a pathology department. When Rob was talking about, there was no pathology department or residency. Now they've started a residency, and thanks to Penn in part, that residency is doing well. And I know you've gone over from CHOP, right? Yeah. So, which is really good, Howard.
Are there any programs like this in other countries, with other universities?
Does Penn have a program like this in other countries? I don't think so. Doesn't mean we shouldn't. But again, it gets to who's going to fund it. You know, we were lucky. PEPFAR came along and helped us. ASEF started it. And I have to say the School of Medicine and Amy Gutman University have supported the program financially. They supported us. And the Department of Medicine supported the program. So Larry has contributed, I would say generously, and before Larry, Arthur was a very generous contributor to the program. But not enough to go beyond Botswana and barely enough to meet maybe 8 or 10% of our budget. Now, are other schools doing that? I think the ones that have programs that are substantial are the schools of public health. Those are the ones that have a big footprint, are all over, and they have multiple programs, you know. And that's, you know, they have a commitment for public health, global health. They have faculty all over. We don't have that. It's a small, that's why I was getting at, a small footprint. So the ones that have it are the schools that are really in this country that have really strong schools of public health.
Does France have programs in Francophone Africa?
What's that?
Does France have programs in Francophone
Yeah,
Africa?
they do. They do, yeah.
I'm sorry, thank you so much for the talk. It was wonderful. I have a quick question. You said that there was initially some pushback on the research arm. Could you let us know a little bit about where a lot of those concerns were coming from and exactly how you addressed?
What was the first part? I said what?
Oh, that you had said that there was initially some pushback on conducting the research.
Oh, yeah. Where are those concerns? Well, you know, there's this distrust in resource-limited settings that you're going to use them as guinea pigs. That's the pushback. Now, you know, it's not necessarily coming from the ministry and the government people or the university. It's more the lay people that they're worried about we're going to use them as guinea pigs, and they, you know, and if they're and a lot of the medical officers felt that way, you know. But some of those medical officers are not from Botswana. As they develop. You know, when we first started, they didn't really have an IRB in Botswana, and we had huge help from Penn setting up the IRB. They're huge. There was great interest from Penn to help set up IRB. Now, Harvard was there, Baylor was there, we were all interested in research. They had an IRB that met maybe every 3 months, and they didn't have the capacity to do much, and now it's far better, but it's still not easy to get a study approved. Any study we do has to go through the government IRB, the university IRB there, the university IRB at Penn, and then if it's NIH supported, they have to sign off on it. And we have a mechanism in place that can be done in 6 months on average, but that's pretty good. But it's a resistance to being used as a guinea pig. That's really the issue. Yeah.
Thank you for that response. Actually, my first question is
Yeah, yeah. Well, building, you know, the ethics component. At the University of Botswana, they have some very talented people that teach ethics and that are helping to develop the IRB committees across for the country. And we've, you know, there's been several people from Penn. I'll mention a name, Frances Barchi, whose husband left to be president at Rutgers, and she left with him. But she was very involved in training for bioethics in country, and they're good about it. They've taken ownership of the ethical training. They don't have a department of bioethics like we have here, or things like that, but they have a lot of growth to do, and there's a lot of areas for Penn to help. You know, but none of this is easy, because who pays for it? How do you get time to do it? And you know, how do you build it into your life, and so on? Yeah. Okay.
What are the problems at the medical school? Can they be corrected? Are they graduating physicians?
You know, my concern about no school of public health and no department. What's the problems with them? Well, you know, I tell you, the main problem with the medical school in Botswana is it's beyond just the medicals. The dean there has much less authority than our dean. Much. It's not, you know, it's like a dean there has very little say, and it all gets pushed up to the president, which is the vice chancellor of the university. So you're totally dependent on the quality of that person. Now, we've been there a long time. When we first started, they didn't have a medical school yet. The quality of the vice chancellor was super. He was great. Then, when the medical school came in, the next vice chancellor was not a big fan of the medical school. He didn't understand medicine, and he just was not a supporter. Now he's gone, so now they have an interim vice chancellor, and we're waiting to see. But it's totally dependent on leadership. I think that's...
Graduating students?
They're graduating students. Many of their students are high quality, and which is really impressive, because they had almost no good teachers. Yet the students were their brightest students in the country, went into medicine. And they were good. And I don't know, are they staying? Yeah, they're staying. Now, before they developed the medical school, the statistics were they were sending 50 doctors a year to train elsewhere, mostly Caribbean, Australia, Great Britain, 10% return rate. So they said, this isn't working. So they changed to, you know, training in-house, and they're staying. Now, the problem they're going to have is figuring out where to put those students, the graduating students. Because they don't, it's not like here, you apply for residency and you get the best students get the best residency. There, the government decides where they're going to send them, and they could send them to the most remote part of the country, and they'll be miserable. And then, you know, they're just getting to that stage because they just started graduating their students 2 years ago. How are they going to handle that? They don't have that many residencies yet. Only a few programs have residency. So a big problem is, how do you handle all this? There's still lots of concern. Yeah. So a Department of Department of Public Health. Well, I said global health. You know, you could call it. Look, I haven't gone out preaching for this, and you know, this is probably my biggest. I gave a talk to the medical students recently, and I said the same thing. And I met with the chair of medicine recently, and I said the same thing. And I'm going to say it till people tell me to shut up. But I think we need to be advocates. There's a lot of people that are passionate about global health, and what the right mechanism is, I'm not sure. But we need to do more than what we're doing. We're just not doing enough. And the fact that this happened was luck, and it came at a time in my career that was good. I didn't mention that my kids were growing. My wife was able to come with me for most of those trips. She developed her own interest in Botswana, so it was good for our family. We enjoyed it. You know, it wasn't like I was being pulled away, and You know, so you need to solve this. This was, you know, and this group and the next group and our youngsters and have to come up with a solution that's going to work if Penn's going to have a global presence for the next 50 years. We're behind. And some people would say, so what? We're never going to catch up, give up. I don't think that's a good strategy. I think we can catch up, and we shouldn't give up. Yeah.
Identify the areas that need attention, cardiovascular disease,
Hi, sorry. Say it again.
you mentioned areas that need attention there. Maybe have presence there, apparently there. Has any department been discussing with, say, mental health?
Oh, for mental health? Yeah, mental health. Yeah, well, you know, Dwight Evans is no longer chair of medicine, psychiatry. His term has ended. But I think there's a lot of interest at Penn in mental health, a lot, both from a treatment and a research point of view. And I think mental health could be one of our signature programs going forward. It has that potential. It's a huge need. I remember I was at a conference where Dwight Evans started talking about mental health problems in this country and elsewhere, and the amount of interest was remarkable in terms of the audience interest. It's so early in the development there, and the mental health problems are, you know, an HIV population of, you know, 38% of women infected still. You know, there's lots of mental health problems. When I was rounding in the early years, they would present a suicide case and they would laugh. They thought it was funny. Suicide, you know, not a suicide attempt. It was considered, they didn't know how to handle it. You know, the people in the audience would laugh because someone would consider killing themselves. I mean, that was 10 years ago. But that's only 10 years ago. There's lots of room for growth. Yeah, well, Don.
First of all, you're to be congratulated for what you've accomplished.
Thank
I just
you.
wanted to mention that there is a Center for Public Health. It's a university-wide initiative that right now is mostly domestic, but they're looking for ways to expand it. Now are authorized to, I think they actually have some graduates MPH program, but it's mostly domestic.
Yeah.
So the first step perhaps
Yeah.
developing a department and a school.
Yeah, and so the MPH students there is an MPH program for sure, and some of those students have been very active in our program too, that have gone for research experiences in Botswana. Yeah. There was one other question I had, yeah.
So, yeah, one of the major issues when it comes to South operation generally is the issue of sustainability. What happens when funding is converted and so on and so forth. It has been a big issue generally in the South Research Foundation. One of my area of working from so I'm just wondering, do you have a plan considering the fact that you are not going to be there forever?
Yeah. So sustainability is a huge problem. And what do we do? You know, again, I mentioned that I'm no longer running this program, so I can tell you where my thinking is, but I'm not sure, you know, where the thinking of the school is on this. I think I'd like to see us take a multi-pronged approach, but I think probably the overall sustainability, you need a formal structure at Penn that supports this type of thing. You know, this was a program that grew out of a division, and it's now been institutionalized. Penn does support this program, no question, but it's still only a program. And I think the big sustainability for us comes if there's really serious money put into it from the school, from the university, whatever. But in the absence of that, one of the things I was working on was partnering with the School of Medicine and the Ministry of Health. Those are our two biggest partners in country, School of Medicine, Ministry of Health. Partnering with them where they hire someone and they allow me to either top off their salary to make it someone they would actually would want to go there or provide benefits, health care. So we were starting to do that when we had hired 2 people like that, one for the university, one for the ministry that was a partnership hire. So that is one form. Another thing is I think chairs of departments here who want programs could support junior faculty or faculty, but junior faculty are often the ones interested, to spend part of their time in a resource-limited country and most of their time here. And if you have enough people doing that, you can make an impact. So I think the model of having people who are spending some of their time in country, but much of it here, is a model that can work also. But sustainability is a huge problem. And I think we need multiple approaches. All right, it's already way over. So thank you very much.